Big news! Multiple generic entries for Farxiga, dapagliflozin, are expected this April before others in the class. Another reason to prescribe Farxiga today. View efficacy and safety information at farxiga-hcp.com.
Farxiga.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated cardio nerds everywhere are working hard to fight this global epidemic. These are their stories.
Welcome back, Cardio Nerds. I'm Apoorva Gangavelli, member of the CardioNerds Heart Failure Council. Welcome to Episode 6, LVADs Part 2. So far in our series, we've covered advanced therapies evaluation, transplant, and an initial intro to LVAD. Today, we'll discuss LVAD parameters, post-surgical management, and long-term management and complications. I'm joined by the chair of the Advanced Therapy Series, Jenna Skowronski, who serves as chair of the CardioNerds Heart Failure Council and is heart failure faculty and director of Cardio OB at UNC at Chapel Hill.
Thank you, Apoorva. As always, I'm excited for you to be joining us, and I'm really thrilled. This is going to be a great episode with two outstanding guests. So first, I'll turn it over to Dr. Hamza Patel. He's a first-year cardiology fellow at Georgetown MedStar, CardioNerds Academy fellow, and a lead for this episode. Welcome, and thanks for getting us started.
Thanks so much, Jenna. I'm truly excited to be here. I have the privilege today of introducing our guests, Drs. Mark Belkin and Dr. Chris Salerno. First up, we have Dr. Mark Belkin. He's an assistant professor of cardiology at the University of Chicago and a giant in the field of hemodynamics. He began his journey with his medical degree at Rush Medical College and then moved to Chicago to complete his residency, cardiology fellowship, and advanced heart failure fellowship at the University of Chicago. He's contributed greatly to the CardioNerds throughout his time, and we're indebted to him for several projects, especially his contributions to the HFSA guideline series and the Cardiac Critical Care series. Dr. Belkin.
Thank you so much for having me. I'm very excited to be here and for my first opportunity to be with you guys as a faculty member. Very grateful for the opportunities from CardioNerds teams as a fellow. I've learned so much from you guys along the way. Excited to be here.
And now on to Dr. Chris Salerno. Dr. Salerno is a global leader in the world of cardiac surgery. He completed his medical education at Rush University before going on to complete surgical training at mHealth's Fairview University of Minnesota Medical Center, East Bank, and Stanford University Hospital, followed by advanced training in mechanical circulatory support and transplant surgery. He currently serves as the surgical director of the Heart Transplant and Mechanical Circulatory Support Program at UC Chicago. I also learned prior to this episode that he was the second person to implant a HeartMate 3 and the first person to have the patient discharged from the hospital. We're absolutely thrilled to have him on as well. Dr. Salerno.
Thank you so much for this opportunity. It's always fun to talk about something I know a little bit about and have a lot of passion for. So this should be fun.
It's going to be great. All right, let's jump in and get started. So we have a case, as always. We have Mr. H. Mady, and he is a 72-year-old male with a past medical history of ischemic cardiomyopathy with progressive heart failure over the last 5 years. His LVEF is 10 to 15%, and his RV is read as moderate on his transthoracic echo. He's now on milrinone 0.25 at home, and he's evaluated for advanced therapies and approved for LVAD. He was admitted 2 days prior to surgery and optimized with a Swan-guided inotrope titration and diuresis. The morning of surgery, his CVP is 8, his PA pressure is 30/17, and his pulmonary capillary wedge pressure is 17, and a PAPI calculates to 1.6. You're part of the team landing him in the CVICU as he arrives from the OR. Dr. Salerno, what are some of the key components of immediate postoperative management that are important for our listeners to consider?
You have to protect the RV, and so hopefully the surgeon did a good job of optimizing the operation, minimizing blood loss. But when that patient hits the ICU, you have to be careful of a couple of things. One, you need a high enough MAP to obviously perfuse the RV and perfuse the patient. For me, that's probably 65 to 70. You have to minimize overvolume resuscitation and use a combination of inotropes and pressors. And then you have to metabolically make the patient perfect. Little things can affect pulmonary vascular resistance, like hypoxemia or hypercarbia or hypocalcemia or metabolic acidosis. All of that you have to optimize to create the right environment for the RV to thrive. And the last thing I'll be thinking about is the rhythm correct, and do I need to fix it if there's AFib or VT or something in that variety. Other things I want people in the unit to look for is your bleeding. If so, to have a coagulopathy after reverse, and then as rapidly as possible, get a neuro exam because one of the dreaded complications of this therapy is a stroke, and if the patient suffered one, I want to know immediately.
Those are great points, Chris. And I think that's why we work so well together in the ICU, because a lot of things Chris is talking about, we've actually put together into what we call like an RV protection strategy. And the importance of early post-operative care is really paramount in mitigating RV failure, both early and then later on. And so while kind of a lot of centers use a combination of the parameters that Chris just spoke about to manage the acute post-operative setting, we actually took this in an algorithmic fashion. And this was actually mostly led by one of my colleagues, Dr. Anthony Canalides and Dr. Jonathan Grinstein, and then of course our Salerno and the rest of the team. And what we did is we took an intended pilot study where we randomized patients to this RV protection arm versus usual care. And usual care, of course, is up to the discretion of the treating physician and the typical fighting between medicine, surgery, anesthesia, critical care of how they want to manage it. But the RV protection arm had this kind of comprehensive upfront RV management approach where we targeted RV afterload. So you were on inhaled nitric for the first 40 hours post-op. We targeted pulmonary capillary wedge pressure less than 18, targeting RV preload where CVP goes by 8 to 14, RV cornea perfusion, as Chris mentioned, having a higher MAP. So MAP goal about 70 to 90, make sure your hemoglobin is above 8, RV contractility via rate and rhythm control. So looking for sinus rhythm and actually a little bit higher heart rate above 100. And then having appropriate vent settings with your oxygen saturation, PaCO2, plateau pressures, PEEP, et cetera. And then we actually added a echo on day 1 and post-op day 3 to look at, make sure the septum is midline to kind of look at RV geometry. This is, again, taking a lot of those things that a lot of people take some, leave some stuff, and putting together and forcing it. Again, this was a pilot study of only 20 patients, or 10 in each arm. But even in this very small study, there was a significant reduction in combined hemocompatibility and hemodynamic related events. In the RV protection arm, but there was 0 out of 10 versus I think it was 3 to 4 events in the other arm. So it's something that we've been now making more standard of care in our unit and obviously working towards more ways to study that.
Amazing. The people's ventricle. I feel like everyone loves the RV now. But I guess, so my next question for you, Mark, was going to be, you touched on hemodynamics. I'm just curious, you mentioned inhaled nitric. I grew up in facilities that liked inhaled epoprostenol. I think that often comes down to whatever contract you have with the company and whatever's cheaper. But I'd love to hear about if you have like preferred pressors. I know this is often really kind of preference without an enormous amount of data, or if you have that. And then we mentioned that this patient's TAPI was 1.6 prior to surgery. And so how do you, in thinking about how to really lever on the right ventricle, incorporate TAPI going into surgery whenever you're thinking about them coming out?
Yeah, and I'll briefly touch on the vasoactives and move into the hemodynamic question. But for vasoactives, I will say for the study, for instance, we preferentially use norepi and vaso for vasoactive support. And then if contractility is needed, we'd use dobutamine or sometimes even dopamine, even though I know that's less widely used. Overall, we were trying to avoid Norepinephrine, given some of the systemic vasodilation and hypotension can be associated with that, to try and keep up the coronary perfusion with the MAP for the RV. In terms of hemodynamics, starting with the preoperative hemodynamics, so the thing that I most strongly consider part of LVAD, look at right heart function, is how do we think the RV can handle the LVAD and the extra flow in someone who's been living with heart failure. So looking at PAPI, you mentioned RA to wedge ratio, look at RV stroke volume index or stroke work index. Many of these metrics are incorporated into the various RV risk scores and have been shown to be associated with post-operative outcomes. So briefly diving into a couple of them. So PAPI, for instance, is pulmonary artery pulsatility, systolic minus your PA diastolic, divided by your RA pressure. This reflects the pulsatility of the right side of the heart via the PA pulsatility in the context of the load it's handling, which is your RA pressure. So using cutoff of about 2, this was first known to be an independent predictor for need for RVAD placement after LVAD, and this is back from 2016 out of Stanford. And if you look more recently, the meta-analysis, I think from a couple of years ago, that had, I think, 32 different studies looking at almost like 5,000 patients, all finding the same cutoff. I think it was technically used like right around 2.1. Other metrics I think are really good. So RA to wedge ratio is very helpful. Mark Drasner and Lynn Warner-Stevenson, first in the late 90s, really just showed that in kind of the normal hemodynamics, your RA is about 0.6 of your wedge. So it's easier to remember for the listeners, about half. So if your RA is 5, your wedge should be 10. If your RA is 10, your wedge should be 20. And that really gives you a sense of, if you have elevated filling pressure, they should go up together. But if the RB is struggling out of proportion to your wedge, you'll see them start to get closer together. For instance, I'm way more worried about someone whose RA is 20 with a wedge of 25 and someone whose wedge is higher at 30, but RA is 15, because that's someone whose RB is struggling versus just concordant elevated filling pressures with the good LV. Stroke volume index has been, and stroke work index have been associated with RV failure. I will say I think they're admittedly used less often in clinical practice just in terms of the complex of the calculation. But what's interesting about them, if you do look at kind of the data behind stroke volume index, especially, and then PAPI, is that, if they're low, do we just not do an LVAD and say, oh, well, they're going to have RV failure? And it's actually, the question is, how much can you optimize them? And for example, Cleveland Clinic noted a combination of initial PAPI plus optimized PAPI was a very strong predictor of post-op RV failure. So can you make it better? And then Ryan Tedford's group joined with Penn, so MUSC and Penn, and looked at change in stroke volume index after giving nitroprusside. And those who improved their RV stroke volume index had less RV failure afterwards. The overarching theme here is that patients that showed degree of right ventricular reserve, so they're improving their RV function with optimization, usually have a reduced risk of RV failure. And the final thing I'll say about this, that being said, though, I think there is the jury's still out a little bit on this as we increase understanding in the field of kind of RV hemodynamics, that even if optimized, usually someone who looked bad at one point has a poor substrate and their risk of developing RV failure afterwards is still higher, and something that you need to be always wary and always look out for, even if you got their PAPI or their other RV metrics into a good state going in. Until that, you got to be very cognizant and detail-oriented when they're coming out of the OR.
I think one of the problems with optimization, I'm a big believer in, is the patients can be rapidly de-optimized. They go into the operating room, they get intubated, there's an inexperienced anesthesiologist, they pour a couple of liters of fluid into them, and next thing you know, you're de-optimized. So the strategy really has to be intraoperatively managed by the surgeon. And when I do LVADs, I ventilate the patient the whole time. If I have them on nitrogen, I started even before we make an incision, and we have to really be cognizant of volume management. If it takes constant attention to make that patient safe in the OR, I ought to think about putting an RVAD in, because that's not realistic in an ICU and during transport.
I think that's a point that was made during our first LVAD episode. That they really talked about how you have to know what happened in the OR, and if you don't know what happened in the OR, you're flying blind in the ICU. I found that to be really true during my transplant and VAD year. It made so much more sense when people explained to us exactly what was going on, but I think often that sign out isn't passed. You don't end up hearing about it whenever you're taking care of the patient. So thank you for articulating that.
I think that's really helpful to know as a first year fellow. I haven't rotated on the unit yet, but just thinking about how what happens in the OR is going to dictate your management as well.
One of the things is the use of 10-bar beds is cyclical. It's probably more common now than it was years ago, but it's a bit of a security blanket for bad management or for bleeding. Some surgeons see it as being defeated if you need it, but you have to understand your environment. And if you don't have expert post-op care, put the RVAD in.
Yeah, and the data, as Chris knows, most of the NSAIDs really showed about upfront RVAD versus going to get an RVAD later leans towards better outcomes when you do the upfront RVAD. And of course, that's because if you have this early RV failure and you get it cascaded to someone who then ends up on dialysis, then ends up stuck on the ventilator, and then that builds and builds, and then you get all your ICU complications. And so really that really upfront aggressive strategy to preserve your RV is what is then going to avoid a lot of those early complications that really affect the late LVAD outcomes or medium-term outcomes even.
Yeah, I think that's a perfect segue into my next question. Just going back to the case and talking about postoperative complications. The patient, about 2 hours after they arrive to the ICU, the bedside nurse alerts the team that his pressure requirements have increased significantly over the past few minutes, and the LVAD's now having a low flow alarm. His SWAN is in place, and we collect numbers. The CVP is at 20, PA pressure is 35/20, and we're not able to wedge. So Dr. Belkin, what are some of these postoperative complications that you'd be worrying about? And what might the hemodynamics suggest?
Can we ask what the blood pressure is?
Let's say it's MAP of 55. Pressors are going up.
All right.
First of all, what's interesting is actually if you look, we know a lot about PAPI, right? And what's so key here is if you look at the pulmonary versatility, pulmonary artery pulsatility, it actually hasn't changed from this patient compared to pre-op. He was 30/17. Post-op, he's 35/20. Great. It's 15. It's even better, right? But the huge difference, of course, now is that a CVP has gone from 8 to 20. So your PAPI has gone from 1.6 to 0.75. And what it's showing you is the reducibility of the RV to generate inadequate pressure with this reduced pulmonary artery pulsatility in the face of greater load from the RV. And what it's showing is as the RV is failing, that fluid's backing up. Now, of course, RV failure isn't really the only early postoperative complication that will cause this higher CVP. Tamponade can present pretty similarly. So patients, of course, come out with mediastinal drains, but if there's significant bleeding, the drain isn't working as it should or isn't placed adequately, or nothing that ever happened, but it gets malpositioned during transport, more likely, Chris is laughing, then tamponade will present with this constrictive picture with elevation in all your filling pressures. And so what's key here is this early on is the two big things differential really need to be RV failure and tamponade. So putting an ultrasound probe on the chest, or with the bandages if you can't get a good image, doing a TEE is key to make sure that this isn't a situation that they need to go back to the OR to manage tamponade versus addressing what you have now is acute postoperative RV failure.
Yeah, I would say for me as a surgeon, this is tamponade, so proven otherwise. I have to feel responsible. Even if the chest tubes don't drain, it doesn't mean the patient is not bleeding. So in addition to a ultrasound, a good old-fashioned chest x-ray is very helpful at assessing large pleural effusions or a wide mediastinum. Pretty quick, you gotta figure out, is this RV failure or tamponade?
Yeah. And so obviously we talked about with tamponade, you'd be going back to the OR to manage it. Dr. Salerno, is there anything else that you would need someone to return to the OR, especially within that first acute period, maybe the first 12 hours of surgery?
Other than tamponade? I think if they had RV failure that was not responsive to inotropes or metabolic correction, it depends what kind of RVAD you want to put back in, but I think if they return to a interventional area, whether it be a cath lab or OR, is reasonable to provide temp RV support. I've never had to go back for other acute problems that you can fix at the bedside, but in RVAD's a good reason.
I guess something that I think that was a learning curve for me was understanding what your surgical threshold is. And so I guess for our listeners who haven't had the opportunity to live in the CVICU yet, is it really high? Is it you're thinking about it, so you're just going to take them back if you have OR space? How do you think about that?
A couple of things. One is if they're hemodynamically compromised, it's an emergency. If you have the luxury of time, you can optimize them a bit. Correct their coags, change inotropes, but my bias is early return. Some centers choose to leave the chest open on everybody. We don't do that. We never have, because we can't predict a trip back to the OR. For me, if somebody's drained more than about 800 cc's to a liter, or they have hemodynamic compromise, I'm taking them back to the OR. I think I may be a bit more aggressive about that than other surgeons, but eventually bleeding creates RV failure, renal failure, liver failure.
Thank you. Yeah.
Going back to our case, the patient is now post-op day 1 and doing well after returning to the OR for washout and hematoma evacuation. He's currently supported on dobutamine 8, Epi 2, inhaled EPO 50. A medical student is doing their acting internship in the CVICU and has never seen an LVAD before. And they asked for a primer on VAD parameters. He did listen to episode 5 of our series and knows that the HeartMate 3 is a magnetically levitated centrifugal pump, but doesn't understand the number he's seeing. Dr. Belkin, you've helped so many of us understand VAD with your paper on HeartMate 3 physiology. Can you walk us through the basics?
Great question. And this is love this teaching kind of point when we're in the ICU. And so there's 4 parameters seen on an LVAD controller or the screen if you're using the console in the hospital. And these are flow, which are in liters per minute in the top left, speed and RPMs in the middle, pulsatility index, which is unitless on the top right, and pump power, which is in watts on the bottom right. The only thing you can change on the LVAD, right, is the pump speed by adjusting the RPMs. The usual operating range for a HeartMate 3, which right now is the only current LVAD on the market while other ones are undergoing investigation. So I talk most about HeartMate 3s here. The usual operating range is 4,700 to 6,200 RPMs, with a median around 5,400. Occasionally you'll see higher speed, particularly if patients have larger BSAs or an attempt to overcome significant aortic insufficiency, which is not going to be the topic of this discussion. So based on the set speed, the onboard computer within the HeartMate 3 in the intraperitoneal device is able to measure the rotor drive power in isolation, which is the power needed to operate the rotor and generate blood flow. So flow is not measured directly, but is rather an estimate based on the power being used by the pump. And so this becomes key. So for the HeartMate 3, there is a largely linear correlation across the normal operating speed. At the high extremes of systolic flow, the power does become less accurate. This is important to understand because 1, as it relates to changes in flow and PI, which we'll discuss in a moment, and 2, to understand clinical scenarios. Most drastically, you may see an abrupt increase in flow in a patient with a rotor thrombus. The thrombus within the rotor, in fact, makes the pump use more power to spin, and the pump interprets this greater power as increased flow, when in fact the patient may be functionally flowing less blood through the inadequately performing LVAD. Luckily, rotor thrombus is vanishingly rare with the HeartMate 3 technology, unlike the close to 10% rate with the prior HeartMate 2. So, if pump flow is equal to the rotor speed divided by the difference in the pressure between the inflow and the outflow cannula. So inflow cannula is in your left ventricle, outflow cannula is in your aorta. So at a fixed rotor speed, device flow is inversely proportional to this difference between the LV and the aorta, with the side of the two cannulas. So the greater the difference between these 2 points, so think high blood pressure or low LVADP, will result in lower pump flows, right? It's harder to overcome this pressure difference, if you will. The relationship between the pressure difference and flow can be visualized through HQ curves, which are unique to each pump and set speed. And so in the paper that you reference in JCF that goes through the review, there's a lot of pictures of HQ curves. But in general, the HeartMate 3 has this flatter HQ curve at lower speeds, and it gets steeper at higher speeds. Basically, small changes in the pressure difference will result in bigger pressure changes, which is why we get really concerned when patients get higher MAP. We can just bring their MAP down a little bit, their flow will increase. And then there'll be smaller changes at high speeds due to the more steep aspect of the HQ curve. And so, of course, in a living, breathing patient who has an LVAD, the pressure in the LV and aorta are, of course, not stagnant. And that leads us to pulsatility index, or PI. Since the pressure difference between the LV and the aorta change on a beat-to-beat basis, the flow oscillates in relation to this. The difference between these max and min flows divided by the average flow is the PI. And which is technically actually calculated off of the averages of pump power, but because it's not directly measured by flow, but that kind of is, we use flow in these discussions because that's better to understand. So again, as your aortic pressure goes up and down, your LV pressure goes up and down, the difference between the pressure between the LV and the aorta is changing, and therefore the flow is changing. And that change in flow is essentially how you get to the calculated PI.
Mark, you're one of a kind with this stuff. Thank you. Okay, so for our listeners, to summarize, you set the pump speed, you know how much power the pump is using, and then it uses that to calculate a flow. Something, though, that I think is confusing, even though you just walked through it so beautifully, is the pulsatility index, PI. So I'm just going to ask you a little bit more because I think it's less intuitive for a lot of us. Do we want it to be high? Do we want it to be low? What does it mean if there is a PI event? Can you talk us through that a little bit?
So great question. I'm going to give you the prayer of how to think through PI when you're looking at a patient, particularly one who's struggling. A relatively normal range for a PI is somewhere in this kind of 3 to 5.5 range. However, and PI itself is not an issue, but it can alert us to underlying physiologies, particularly in the context of flows. And this could be its own lecture, but we will try and keep this brief. So conditions that will increase the pressure difference between your LV and aorta. So again, think hypertension, or think someone who's GI bleeding has a very low LVADP, or RV failure, where the RV is not actually filling the LV. And so therefore the LVADP is low, but because of RV failure and lack of forward flow, these will all have lower flows. So again, the pressure difference is high between the LV and aorta. You will have, therefore, more pressure to overcome. You have a lower flow. However, the PI here will be high because if you look visually, if you look this up of the HQ curve, small oscillating pressures during the beat-to-beat cycle will end up basically those small changes lead to larger changes in flow. So you have low flow and high PI. And the differential should be in someone with low flows, high PIs, should be hypertension, RV failure, and then hypovolemia most commonly. So this needs to be further informed by clinical exam. Again, someone who's having a lot of melena, low hemoglobin, think GI bleed. Someone who is very hypertensive, fix that first. Clinically have RV failure, LVAD, JVD, all that kind of stuff. Focus on that as well. So it still becomes very important.
And Mark, in all those cases, the common denominator is underfilling of the LV.
Correct. Exactly. Anything that will underfill the LV. And which is why the pump itself, it's super smart, but also kind of dumb in that it's only reading the pressure between the LV and aorta. It has no idea. Again, you can take 2 patients. One is super volume overload, RV failure. The answer is diuretics. The other one is hypovolemic. Don't diurese them. And so your clinical exam still matters here. Don't be scared of the patient with an LVAD. Go look at them, examine them like you would anyone else. But this is how you can use the pump parameters in that context. However, if the clinical exam does not fit with any of these scenarios, then, so you go through those first, I say most commonly, again, hypertension, RV failure, hypovolemia, GI bleed. You can think about an inflow or outflow graft obstruction or kind of a kink. So think of it as putting your thumb over the end of a hose. If there's an outflow graft kink, when the LVAD is seeing higher pressure via the outflow cannula, and it'll similarly have low flows with higher PIs in response to this partial obstruction. Now, if this turns into an almost complete obstruction, or similar, kind of like the tamponade scenario, you'll get an issue where you have low flows, but also low PIs because it's such complete obstruction that it can't tell that oscillating cardiac pressure between your LV and your aorta. And you get this fixed high pressure difference, but without much pulsatility. On the totally other end of the spectrum, you have patients with, for instance, most classically severe aortic insufficiency, which is usually a longer term complication that persists even in the HeartMate 3 era. And in this case, you will see lower MAPS and higher LVEDP because you're having some blood recirculate with aortic insufficiency. So the pressure differential between the inflow and the outflow cannula is now lower. So flow will be inversely higher. But at these higher speeds, you're on the steep aspect of the HQ curve. So the same differences are actually a narrower difference in flows. So high flows, low PI, you classically think of severe AI, and that's converse what we talked about before. And then lastly, if you have higher mean flows, but still have really larger PIs, this can be a situation in which the LV is contracting more vigorously with frequent aortic valve opening, as would happen in a normal physiologic state, in a well-accommodated state. The pressure changes in the cannula could be ranging from essentially 0 as the LV exceeds the pressure of the aorta to something, let's say like 100 or 120 with an LVEDP of 5 and a systolic blood pressure, let's say 110. So you'd see these higher mean flows, but also higher PIs. And this is someone to consider recovery. So this is someone to maybe look at with an echo, see is their EF doing really well now, and start thinking about that their heart is recovered with their LVAD therapy.
I think the one other confusing part of this is inotropes can affect the PI. If you think of the PI as a measure of the LV's pulsatility, which is exactly, sometimes see after surgery that the PI goes down despite a good clinical environment as the inotropes are weak. So it's a tool, it's one to be interpreted, but not worshipped.
Yeah, no, correct. And I will say, I think a lot of the importance of understanding PI, to be honest, helps you just understand LVAD physiology. It's not a totally secret code that the answer is blaring right there. It says RV failure if it looks like this. Again, you have to put it in the clinical context. And to your point, Chris, about the PI coming down, right? And so what we're seeing there often is that you have someone who has very advanced heart failure that appropriately is getting an LVAD that gets some rocket fuel coming out of the OR, is generating a little bit more pulsatility in that context. And then a mixture of either A, we start worrying RV failure coming out, and obviously we always have our eyes up for that. B, sometimes actually the inotropes get them hypertensive. So we've seen where we need to start coming off the inotropes a little faster. And 2, or coming off the inotropes where they're settling back into a little bit lower pulse pressure state, consistent with their very advanced heart failure, that they're really not able to have the same pressure in there to add to that PI. Again, because if you have someone who's a very sick heart and pulse pressure is 10 or something, even if you have these lower flows, the PI won't be very high because that difference is very significant.
And also don't forget that the numbers are only as accurate as the data. So you have to make sure the hematocrit is set correctly.
So for Hamza, if you haven't done this, you actually every day should go in when they're in the ICU and set their hematocrit to what it actually is, because again, it's all calculated, right? And it's like whenever this is my like passion project, whenever somebody tells me what an FiO2 is, but they don't tell me what the hemoglobin is, I'm like, well, I don't know. 32 might be great. Like it depends. Is their hemoglobin 4? So you have to be able to give the pump the opportunity to give you accurate numbers, and that requires them to have a hematocrit as well.
We're talking about high flow, high PI generally means LV recovery. Is there anything else you should be thinking about? Like, I know we were talking about like different clinical scenarios that would be like problems with high flow, low PI and low flow, low PI, but is the combination of high flow and high PI like always considered, all right, LV recovery?
This is where I will say, realistically, as much as PI is fun to talk about, so many things can factor into the PI related to also like what speed you're on, adjusts where the HQ curve is, which will change your pulsatility. If, again, what degree of aortic sensibility, their age. So all these things kind of lead into PI that on its own, like someone who's crazy hypertensive has a low flow and the PI isn't as wide as you think if the PI isn't 12 or something, doesn't mean that the problem isn't just hypertension. And so I think the most common thing, again, in thinking about education for our listeners, I think the most common thing you see when you are overnight in CC or whatever, that is you're coming in is often an LVAD with low flows. And so for that, again, the 3 major things that really you need your clinical exam is going to be how hypertensive are they. And remember, for an LVAD, you'll map over 100, even over 90 is not ideal, but over 100 will start to generate those low flows usually. Again, RV failure, which is looking essentially for a heart failure type clinical exam, or hypovolemia, which in the context of LVADs we think of could be either a GI bleed or something more like a septic vasodilatory picture. And that'll also mess up your PI a lot. And so for me, Those are the things that you can immediately manage with with a low flow as a resident or fellow that you're assessing that. Again, if that all looks normal, you know, these patients come in normal pressure, they don't have heart failure, not bleeding. And that's where you start thinking about, and obviously talking with your fellow attending, things like that, about do you go looking for the optical cannula obstructions and kinks that are going to be a little bit more difficult to fix and more nuanced than usually in the middle of the night.
I would just say as a simple-minded surgeon, if you're not able to figure it out, use imaging.
Yes, 100%.
Yeah, definitely. I feel like just putting a probe on their chest would help a lot.
Imagine if you had a DE probe that was in the patient until they were extubated. You can optimize the RV and assess valve function immediately.
Switching gears for a moment, how do we think about patients and anticoagulation post-LVAD implantation, especially because we are balancing bleeding risk?
This field is always cyclical, and we have to remember that what works for one pump doesn't work for another. But I think a lot of people now just go straight to Coumadin when the patient's extubated, and they don't worry about periods of time without anticoagulation immediately post-op. At our center, we tend to start very low dose heparin when the chest tube output is minimal, and we start Coumadin as soon as you're extubated, and stop the heparin when the INR is about 1.6. But with this pump, I have no concerns about stopping anticoagulation either early after surgery or much later if a patient's bleeding.
Yeah, the long-term strategy for HeartMate 3s is technically guideline would be recommended would be using warfarin with INR goal 2 to 3. However, there are growing data for using like Exaban. The DOAC LVAD study of as published shown in his group at Nova, they randomized the 30 patients to warfarin versus Exaban and didn't know any hemocompatibility related adverse events in the Exaban group after 6 months. But there were 2 major GI bleed in the warfarin group. This, of course, is a pilot study and leading to larger dedicated trials. And then additionally, anecdotally and anecdotally, we all have this experience. And then there's obviously published reports of patients that are able to be off warfarin or anticoagulation for longer periods of time. It's a different, with for instance, HVAD, if you needed a procedure that it was off of anticoagulation, you usually had to come into the hospital to be bridged. It was not really an option to not to warfarin. Again, it's relatively off-label, but I think anecdotally, a lot of centers feel comfortable with patients being really temporarily off of warfarin. And many times when they've had a lot of bleeding issues, more longer term. Of course, that it's, again, not a direct recommendation. It should be dealt with on a kind of patient by patient with your attendings. And then the other aspect of it, not just warfarin, is an aspirin therapy. So it was routinely recommended that all LVAD patients be on a baby aspirin, in addition to warfarin, and then every other aspirin study, I think, which ends up being either neutral or shows horror. There was the multi-center HeartMate 3 randomized trial, and patients randomized to aspirin versus placebo post-operatively after implant with LVAD with HeartMate 3, and resulted in a significant reduction in major non-surgical bleeds without any significant increases in thrombotic events in the patients who were off of aspirin. So we now largely defer using aspirin in LVAD patients following implant unless you have a really good reason to use it. So for instance, let's say they're a bad ischemic, and they just got a stent to their RCA 2 weeks before their course end up with an LVAD. That's something you probably want to leave on aspirin because you worry about RV failure and the coronary flow you get from the RCA, or either honestly another coronary artery, or again, any other kind of stent purposes that you think you need aspirin. And the other part is that Aries only covered freshly implanted LVADs. And so much like other studies, that's different than the decision to withdraw someone from aspirin who's otherwise tolerating it. So more data is coming there. Dr. Hiro and University of Columbia are doing the extended Aries trial, which I know we're one of the multi-centers a part of. Again, similar where patients may be randomized to aspirin withdrawal versus continuation, those who already had HeartMate 3. So that should we should have more data in the coming year or so about definitively what to do with aspirin after HeartMate 3. But then as Chris alluded to the beginning, it's very pump specific. And as the new pumps come on the market, we're going to have to really understand and adjust how to use them safely with our patients.
I think that's really important. All these recommendations are HeartMate 3 only. The LVADs will be entering a widespread trial with 47 sites. Shortly, we've been lucky enough to have some experience with that pump, but in that trial, warfarin and aspirin are required. I think whatever you do, you have to remember it's pump specific, which creates management challenges. I think the use of non-Coumadin anticoagulation will be on the rise. And the next issue will be, what's the right dose? And I don't think we know yet.
I really look forward to the day where it's completely acceptable for me to use Apixaban in these patients. I think that would make everybody's life a lot easier, but we will see what the data shows.
There was a recent paper that looked at 2.5 milligrams instead of 5, which is what Dr. Shaw did, and the short-term outcomes were equivalent. So the jury's out, but it'll be exciting if we can do that.
Our next patient is a 35-year-old female with a past medical history significant for non-ischemic cardiomyopathy. She has a type mutation and presented in her 3rd trimester. She is now status close to heart rate 3. After a complicated hospital course, she is doing well as an outpatient and feels she has a great quality of life with her VAD, so wants to defer transplant for now as she has 3 young kids and feels like it would be a lot to take on. She calls into her coordinator after experience a driveline tug and was prescribed a course of doxycycline and Keflex. This patient has a great quality of life, but VAD come with complications. What are some of the common ones that you see when you're thinking about long-term complications now?
The 3 biggest ones are infection, specifically driveline, bleeding, and stroke. And luckily, in our era now, the incidence of all of them is a lot lower, even though the vast majority of patients will have a readmission within a couple of years after LVAD for one of these adverse events. As a patient, the one that's probably the most bothersome is driveline infections, and the one that's most deadly is significant stroke. RV failure and valve issues are downstream. I would advise a patient of this age to try and ride the VAD as long as they can, rather chance recovery or to delay transplant. A minor driveline infection is a good chance of being treated.
Yeah, and back up what Chris is saying, the 5-year data from Momentum 3, which compared heart rate to heart rate 2, showed this significant, huge drop in pump thrombosis from, again, 10% to less than 1%. Stroke was down 14% to 5%. Bleeding events, including GI bleed, were down, I think it's 77 to 43%. But there really was no significant change in driveline infection, RV failure, or aortic insufficiency. So when it comes to AI and RV failure, the HeartMate 3 did a great job addressing hemocompatibility related adverse events. So that's, again, your pump thrombosis, stroke, and bleeding. But then when we think about the longer term morbidity, mortality with all that, we're now need to focus on what we have, I'll say my mentor, Dr. Grinstein, has coined the term hemodynamic related events. So that's RV failure and AI. So putting the focus back on that. Both early and late right heart failure and neuroinsufficiency need to be better addressed to improve the long-term outcomes for these patients with LVADs, particularly if we think about using them in younger patients as bridge is to transplant down the road. And then I will say when it comes to driveline infection, it was actually, I think, just published a week or 2 ago at the time of this recording, Dr. Calgar and Dr. Kenmore, a study that actually looked at the kind of ins and outs of how different LVAD centers were managing patients' drivelines and associating that with how they downstream driveline infection stuff. Because again, there's a certain aspect that we talked about at the beginning about vasoactives, every kind of use them a little bit differently. And every center was managing drivelines a little bit differently. And I know specifically using, I believe, the Solanine cream, it was what was one of the biggest things that I believe was associated with a reduction in driveline infection. So there is a great movement toward better standardizing and improving those outcomes as it relates to driveline infection. Of course, then we will see as newer pump iterations with smaller drivelines and the ultimate goal of one day the driveline-less LVAD will obviously eliminate the complication. But for now, it's something that we definitely need to take good care of.
I think the main thing with driveline infections is prevent them. That starts with an operation that follows the principle of bearing the VOR and choosing the right site, patient education, and having site management. And there are people who are out 5+ years that have never had a driveline infection. I really think the planning for this starts in the pre-op period.
Can I ask about sensitization in our patients who are younger and might go from LVAD to transplant? I think there's some conversation that just the simple active, or not this, I take that back. I apologize, Dr. Slick. The complicated, very well thought out act of having a VAD implanted can cause you to become sensitized and cause you to, for those listeners that haven't listened to the episode about patients who are sensitized and need to get a transplant, it makes it much harder. They have antibodies to more hearts. So I'd love to hear your thoughts on that.
Yeah, first I would say is, again, it goes back to the time of the implant. So if you optimize your patient and you avoid perioperative transfusion, you may minimize that. And thankfully, sensitization is less of an issue with this VAD than previous ones. Cardiologists are much better immunologists than I am, but my understanding is that most of these bump-specific antibodies are short-lived. And once you find a heart, the risk of long-term rejection is about the same. I'll let Mark expound.
Yeah, without going to too many details about class 1 versus 2 antibodies or not, so luckily that is on a different episode.
Podcast.
And this is a cardiology podcast. It's not an immunology one.
The general gist is that most studies had shown kind of previously that new antibodies that come on after implant of LVAD, so in relation to the LVAD, tend to stick around less after transplant and tend to be less kind of cytotoxic and causing rejection. So while we don't have every patient, because not every patient was a transplant or VAD eval, assessing what their PRA was before the LVAD and afterwards. And that can, again, every center is specific. Our center is pretty aggressive when it comes to sensitized patients, but including what antibodies you include may determine on, you could also include not only dilutions, all kinds of things, but what are the antibodies related to since getting the LVAD. And so that is something to consider, especially, again, that is center specific. That is something that we need more research on and better understanding as it relates to LVAD to allow more people to be successfully bridged. Because again, obviously becoming very highly sensitive to an LVAD and not becoming a transplant candidate this is not a great situation for patients who got an LVAD as a planned bridge transplant.
Awesome. Thanks.
So where does GDMT fit into all of this? Like these patients, obviously by definition of HFrEF going into surgery, are we continuing GDMT, beta blockers, ACE/ARB/ARNIs, SGLT2 inhibitors, MRAs long term?
I don't want to answer for Chris, but he's going to say, don't put my patient on GDMT in the hospital, which is,
No,
I think
I was going to say that as we enter an era where we should be looking more and more for recovery, they should all be on it. But I leave that up to Mark, so you can tell us when.
Yeah. No, of course, I was joking. I do think, as I'm about to talk about some GDMT stuff, I do think aggressively putting it on in the hospital and someone who's acutely post-operative is not the right thing to do in many cases, or someone who you're going to make hypotensive, exacerbate heart failure, things like that. So the goal is we want to get it on. I'll go through that data in a moment. But to my joke with Chris, definitely something that you are throwing it on post-op day 2 or 3, or even too early in hospitalization.
Just start ARNI before they go into the OR.
Exactly.
The surgeons tend to really love that.
So in general, all of our landmark GDMT trials excluded patients with LVADs, obviously. So the best data we have is from the Restage HF trial. This was 40 patients with LVADs at 6 different centers. They were aggressively titrated up on GDMT with very high goal doses. I think it was like correct 50 milligrams a day. And this resulted in 19 of those 40 patients, 19 of the include patients, 36. 52% of patients being explanted within 18 months, and 15 of those 19 remained explanted over 2 years after explant. One of the other patients went on to transplant, and one patient unfortunately passed. Yeah, most of the data for GMT, though, outside of research, ends up being more retrospective registry type data. And so that is somewhat often confounded by the patients who are doing better, can tolerate more GDMT type question. Our center, actually, we just completed a single center randomized trial, and this was championed by our chief fellow, Dr. Mary Acosta, in which we randomized patients to receive SGLT2 inhibitors or not prior to discharge from their index hospitalization after the LVAD implant. And we were looking for some amount of cardiac reversion modeling in 6 months. We just completed the study 2 weeks ago, so we're still analyzing the data, but the prelim data we presented at THT this past February 2025, and noted a significant reduction in LVAD with the SGLT2 therapy not seen in patients not receiving it. So overall, there continues to be a wealth of information about myocardial recovery after LVAD implant, using GMT as obviously one of the biggest sources there. That ties into all the discussions of using LVADs with younger patients, to get to recovery, maybe not needing any sort of heart replacement therapy, or as a way to patients who are better optimized and better compensated tend to have less downstream LVAD complications of the bridge to transplant. A lot of these efforts, I should just know, are led and organized by Dr. Severus Strakos over at Utah, and highly encourage anyone listening who's interested in this topic to head to the annual UCAR Summit to learn more about this really fascinating part of heart failure and LVAD care.
Thank you, Dr. Belkin. Now looking ahead, Dr. Salerno, what does the future of LVADs look like to you? We've heard some buzz about fully implantable pumps. And is there any real competition coming for the Heartbeat 3? What would be a real game changer in the world of VAD, according to you?
Let's talk about competition first. There's 2 or 3 pumps that will see more clinical use in the short term. BrioVAD, which is a pump out of Asia, which is a full maglev pump with a very interesting driveline, about the same size as HFAB, has started clinical trials in the U.S. and is promising. CoreWave, which is a device that is not a rotor, but a membrane that moves magnetically levitated, has a few implants in Europe and in Australia, and will eventually come to the U.S. VivaCore is a magnetically levitated total artificial heart, which is done about 5 or so implants with very encouraging results, some in the US, some outside the US. It's a niche population. And there's a bunch of other pumps in Asia, which will probably never come to the US. What we all want is a fully implantable system. And unfortunately, I don't see that coming for another 5 to 8 years. The market is just not big enough to force that much of a change in design paradigm. I think that you will see some devices, like the LVAD potentially, where the use of the thoracotomy approach may go up because of the size of the device. Unfortunately, you won't see much innovation for the near future, but I'm optimistic eventually a fully implantable device will come to market. And then I would see to be better peripherals, which don't really impact the surgeons, but do impact the patients. And I hope that will make life with it easier.
Yeah, it sounds like the long-term goal is fully implantable system, but that's not coming soon.
Don't forget, we've had two in the past. The airliner Lionheart, and there was a Abiomed Orofacial heart called the Abiocore, which were fully implantable.
Yeah, so as we begin to wrap up this episode, what are like both of your main takeaways for our listeners, especially those that are getting new to LVADs and trying to understand the complexity that exists?
I think first, I've always been on the lookout for RV failure, particularly early. Preemptive management out of the OR can mitigate the early risk, and less early RV failure ends up with less long-term RV failure. I think two, definitely, I think understanding the idea of the inverse proportionality between that pressure difference between the cannulas and your flow, and let that inform your differential diagnosis, particularly again for low flows, where you're thinking about things that essentially are going to have a low LVDP and or high MAP. And then lastly, I think just thinking about, we didn't get into as much into in this conversation, but I will say just a little step back, thinking about patients who get all that. I know Chris is going to agree here. When we talk a lot about complications, and I think a lot of times trainees see are the patients often you're seeing, let's say, bounce back to the CCU and stuff frequently, are those who often were the most complex patients to get all that, had very acute complications, and tends to, I think, color the view of LVAD therapy as a whole. In general, getting patients appropriately in that window of stage D heart failure before their other organs tend to compensate into LVAD will get them through to the OR in a stable fashion, gets them often a better surgery with less risk of complications, and they're able to live a longer term, more fulfilling life with outcomes, both mortality and morbidity, that are approaching that of post-transplant. But again, like anything in medicine, is the right patient really at the right time? And so overall, it's categorically a life-saving therapy. And for those kind of listening that are worried a lot about the morbidities, I would say if your center does LVAD, go to LVAD clinic one day and see the patients who are coming in where you never would have thought they had an LVAD if they didn't show you their cool t-shirt from Etsy that hides the batteries and everything. It's helpful to see, again, the majority of patients actually do very well with the therapy.
I can't echo what Mark said any stronger. The patients in your CCU are not the people living with LVADs who are thriving. My takeaways: LVADs are amazingly effective at treating left-sided heart failure. I think we tend to overcomplicate this device. It's a stupid pump that's a tool and allows us to unload the LV. Early post-op management, don't worry about long-term issues like AI and GR. Keep the septum midline, minimize MR, don't create TR, and get them through the recovery. And the rest of this GDMT and chronic care is what our back coordinators and our cardiologists do, and that creates the patients who thrive. With an LVAD, you can do almost anything you want to do other than swim. And we should encourage our patients to live a robust and complete life.
Thank you both. Yeah, I decided to go into heart failure when I went to that clinic, which was not at all what I was expecting. But it was, I think that day I had somebody who told me about walking his daughter down the aisle. And then the next patient told me about playing on the floor with their grandkids. And I realized they can live really wonderful, like what they would call normal lives. And I think it's fantastic. One of my main takeaways that I want to highlight that Dr. Salerno really highlighted for us nicely throughout the episode is how important what happens in the operating room is and the impact that it has on our patients in a very long-term way. in addition to the short-term care in the ICU. So don't forget that this is a team sport. That's why we have a surgeon and a cardiologist on to really work with your team, understand what happens to the patients at every stage, and that'll allow you to succeed. So we always ask our last question, always, and I'm going to ask both of you, what makes your heart flutter about the world of LVAD and advanced heart failure care?
For me, to be honest with you, this is sentimental. Don't tell people this, but it's when a patient or a family member gives me a hug and says thank you.
We're not going to tell anyone, Chris, except for the many people listen, the thousands of people listen to this podcast.
30,000 people that listen.
Don't tell anyone, listeners.
Yeah.
I think for me, when it comes to advanced heart failure and LVAD, and I'll let this be a plug for our career as advanced heart failure cardiologist. It's really the dichotomy, the diversity in your day to day, where you can be in the ICU managing a patient, getting them through critical illness to and post and LVAD, for instance, and then go to clinic the next day and see someone who got their LVAD. Either, let's say 6 months ago, they had a really rough course. Now they've left rehab, they're doing well. Or 5 years ago, and they're just thriving and they're doing fantastic. And discussing with them, thinking back to what might have been a tough course where they obviously had very severe heart failure and now essentially don't. And so I think, again, I will say, I think as trainees, this is something that even I opened my eyes. It wasn't even until really the last year of training. We spend so much time learning the ICU, learning inpatient, that even someone saying 3, 4, 6 weeks, that's a short period of time in someone's overall life. And when you get patients through complexity, and even if it takes a couple months to rehab and they come out the other side and they are doing better than they were before with their illness, truly thriving, it really reminds you that everything you're doing kind of has a purpose beyond, again, your service list that week or whatever it might be. And thank you to our surgeons who are doing the simple task of just plugging in the LVAD and the OR for us to get these patients at lifetimes afterwards.
It's important to remember the first HeartMate 3s were put in 2014. There's a bunch of patients who have their original device in and are living free of heart failure. And there's a handful of HeartMate 2 patients who've been on support for over 20 years with the same pump and have had meaningful lives. So a lot of us are transplant focused, but for some people, this therapy makes more sense. And there's others where transplant never be an option. So it's really important to maintain this therapy.
This has been such an incredible conversation. Thank you both for joining us. On behalf of the CardioNerds team and all of our listeners, thank you for your time, your insights, and your heart. We'll catch you all on the next episode with a very special focus on heart failure and the essential role of palliative care. Thanks, everyone.
Thanks for tuning in to another CardioNerds episode. The audio editing for this episode was performed by me, Pace Wetstein. I am an intern in the CardioNerds Academy, House Jones, and an MS1 at LECOM Seton Hill. I invite you to check out the episode page for show notes and references. If you found this episode informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our upcoming episodes. And now, it's time to make like an S2 and split.